Welcome everyone to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 1st, 2024. We do not have a CME code today. This conference will be recorded. Anybody not on the mailing list, make sure you send us an email. We'll get you on there. All our recordings are available in our YouTube channel, so you can go back and watch them if you like. We've had some really good feedback lately about people that are unable to attend them from around the world because of timing that do join us. We have nothing to disclose, and we ensure patient privacy by changing any identifying information. I want to start with a little discussion about an article that Dr. Glassick just put out called Prognostic Scoring in IgA Vasculitis. We've had a lot of talk recently about IgA vasculitis versus IgA nephropathy. Just to remind, this all started out as Henoch-Schönlein purpura. Actually, they were colleagues. The one, Henoch, I believe, was the teacher, and Schönlein was the student originally. But Schönlein described the association of non-thrombocytic penic purpura with joint pain as far back as 1837. And he called the condition purpura rheumatica, but then Henoch added the GI and kidney involvement in 1874. We've been dealing with this nomenclature for a long time, but more recently it's really been referred to now as IgA vasculitis. And Dr. Glassick wrote a very nice editorial in C. Jason, just came out, discussing the prognostic scoring in IgA vasculitis, because it's a difficult, exactly what's going on with crescents, et cetera. His point has been all along that, and I'll quote this is from his article, unlike IgA nephropathy, the diagnosis of IgA vasculitis cannot be made on the basis of pathologic examination of kidney lesions alone. And of course, that's right. It's just a matter of definition. I've always kind of wondered about this, but what do I know? I certainly trust Dr. Glassick more than myself, but I've always just wondered if it really is a separate disease or if it's just a spectrum. For instance, I've seen many patients with bad crescentic GN, with a rash and abdominal pain and joint pain. I've also seen people with crescentic GN with really nothing external, no rash, no joint pain, no abdominal pain. I've seen also patients with rash and joint pain when they've got minimal glomerular abnormalities. So my feeling always thought it's kind of a spectrum, but it really doesn't matter. I think Dr. Glassick's point is that a lot of the literature out there has really focused on I'm not looking at the vasculitis, but IgA nephropathy itself, and we've always been kind of avoid. So it's a nice article, it just came out, I suggest you read it. But I want to point out in the first paragraph, if you could advance the slide, advance again. There's two words that Dr. Glassick uses in this first paragraph, and this is where our first poll comes in. If you could put the poll. I know what eponemic and transmogrified mean. So if you know what these words mean, I want you to vote number one. Or number two is, I have no idea, I'm not sure I can even pronounce them.
That's great.
Number three, I will cheat. Number three, I will cheat and use Google very quickly so I can know what these words mean.
I mean, we're talking about the very first paragraph. He uses two words that clearly I'm number two. I have no idea. I struggled in pronouncing them, but Dr. Glassick indeed is a Renaissance man, and we can always learn from him. And I'm not even going into what they mean. He may be able to defend himself later, but we got to keep going on this. So, a few more votes.
Ended 87%.
All right, we can share. It's pretty good representation. So about, you want to show it?
Should be sharing. 87% said
Okay,
they have no idea.
About 90% say that they have no idea. They're not even sure they can pronounce them. We've got 4 people that absolutely know. So I think 2 of those are liars, but I'm just, I don't know. We'll have to see. For the 4 of you that know, there's now 5 in the audience that know, along with Dr. Glassick. So the question is now, I mean, clearly he is a Renaissance man, but one could make the argument that he's elitist. So I had to Google. I
Am
Googled.
I an elitist?
I put in Google, is Dr. Glassick an elitist? And let me show you what comes up. When this is the exact link that comes up. Hopefully this works.
Dejan gritar mis canciones al
The younger
viento.
Dr. Glassick.
Ya no soy como ayer. Ya no sé lo que siento.
All right.
Me olvidé. Me olvidé.
So I'll leave it up to you if you think Dr. Glassick's an elitist. We can always learn from him, and I can guarantee you if I ever go out to dinner with him, I'm going to have him taste the wine. Dick, thanks for being a good sport.
Good,
Uh,
good.
I think we get to the case now. Bhavna, I think you're going to read it for us.
Yes. All right, can everyone hear me? Okay, so we have a 33-year-old Hispanic woman with no significant past medical history who presented with chest pain and shortness of breath. She was found to have an acute bilateral pulmonary emboli and was started on a heparin drip. For the past few weeks, she has noticed swelling in her legs that have made it hard for her to wear shoes. Around the same time, she noted frothy urine and hematuria with occasional clots. Denies any recent prolonged immobility or history of miscarriages. She has had 2 uncomplicated pregnancies. Of note, she had a recent history of COVID-19 infection 1 month ago prior, which was uncomplicated. Review systems pertinent for shortness of breath, chest pain, bilateral lower extremity swelling, and hematuria. No significant past medical history. Her surgical history is a cholecystectomy 10 years ago. She was on no medications prior to this admission, denied any over-the-counter or herbal medications, and no NSAIDs. No known drug allergies. For social history, denied tobacco, alcohol, or recreational drug use. She has a family history of Alport syndrome and paternal grandfather, and no family history of SLE. On physical exam, she was afebrile, blood pressure 152/93, pulse 85 beats per minute, respirations 23, 98% on room air. She weighed 132 kilograms, height 5'3", BMI 41.07. On exam, she looked non-toxic, no acute distress. She had no oral lesions. Lungs were cleared auscultation bilaterally. She had 1+ pitting edema in bilateral lower extremities and no rashes. Laboratory data and imaging. CMP, sodium showing 136, potassium 3.8, chloride 108, bicarb 21, creatinine 0.61 milligrams per deciliter, BUN 13, adjusted calcium 9.7, albumin 1.8, AST 30, and ALT 36. CBC with white count of 9.78, hemoglobin of 12.0, MCV of 86.2, and platelets of 233. Lipid panel showing cholesterol of 201, triglycerides 145, HDL 42, and LDL 130. Serologic workup was positive for ANA with a titer of 1 to 320. Anti-double-stranded DNA was 9.0, and SSA was positive greater than 8.0. Hep B, Hep C, HIV, ANCA, anti-RNP, anti-Smith, SSB, and anti-GBM, as well as anti-PLA2R was negative. Anti-cardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant was also negative. C3 was 118, C4 25.1, rheumatoid factor 13, and SPEP and UPEP with no paraprotein. Her urinalysis showed 4+ protein, 3+ blood with 37 RBCs, 10 Highland casts, UPC with 4,504 milligrams per gram, and UAC was unable to be calculated due to excessive microalbuminuria, and her urine pregnancy test was negative. CTA chest showed bilateral pulmonary emboli involving the segmental and subsegmental branches. A TTE showed an ejection fraction of 55 to 60% with no regional wall motion abnormalities, and she did have right heart strain. Kidney ultrasound showed a right kidney of 12 centimeters, left kidney 12.5 centimeters, and no hydronephrosis, and there was no renal vein thrombosis. After anticoagulation was held, a percutaneous renal biopsy was performed.
Wonderful. Any questions on the protocol? Let me hand it over to Dr. Gashty then. We don't have our poll because we used up our first one.
Roger,
Yeah, Dick.
I'm a little transmogrified by this this protocol. Anyway, I want to be sure the ultrasound that says that there were no renal venous thrombosis, was that a Doppler or just a routine ultrasound?
Doppler. The ultrasound was there. We also got Dopplers.
Okay. Okay.
I'm curious, was this sudden onset as far as the proteinuria and everything, or had this been percolating for a while?
We don't know about the actual proteinuria, but we do know that about, what was it, Bob? 4 to 6 weeks ago is when she noticed some swelling in her legs.
Yeah.
And then she came in about 3 to 4 weeks later with the PE.
Can I ask one more question, Roger?
Of course.
When you say anticoagulation was held, was the patient put on any bridging heparin?
Yeah, what we did was, she came in actually, and she was sent to Rush to be evaluated to see if she needed a TPA infusion versus an actual thrombectomy. They decided to do neither and just put her on heparin and convert her over to Eliquis. That's when we saw her and we did the workup. So we decided not to do an urgent biopsy, even though I kind of had her there, because I thought if her serologically, we didn't know if she was PLA2R positive or if she had lupus or anything. So we sent off the workup and we sent her home on Eliquis anticoagulation for her PE. And then when the serology came back, we brought her back in, took her off the Eliquis, rebridged her with heparin, did the biopsy, and then sent her back out on Eliquis.
Okay, thanks.
Great. Yeah, that's a tough one. Because this is not prophylactic anticoagulation. This is, life-threatening anticoagulation. And it's a tough call, how you do it, what do you do, how long you bridge, how long you stop, when you restart it, you treat empirically, and this is a really tough one, but obviously you got through it, so congratulations. I'm going to hand this over to Dr. Gashty. Casey, you want to walk us through the case?
Sure. So we have a 38-year-old young woman who essentially presents with what appears to be sudden onset of nephrotic syndrome. She has bilateral pulmonary emboli. So this all appears very acute. She's hypertensive. She is swollen on exam, and on laboratory evaluation, she has some positive lupus serologies with ANA double-stranded DNA, although her complements are normal, and she also has a positive SSA. So the differential in my mind, obviously based on her age and based on the positive lupus serologies, I would think that she would have lupus. And if I had to pick a lesion in her, on the biopsy, I would probably pick a membranous lupus. Her serum creatinine is 0.6, which sometimes you have to be careful with saying that's normal, because you can have a lot of inflammation in the kidney of a young person with even crescents or necrosis and have a relatively normal serum creatinine. But that being said, 0.6 I assume is pretty close to baseline or normal for her. So that, plus the fact that her complements are normal, but then she has such a severe degree of nephrosis to a point where she has bilateral PEs, makes me think more towards a membranous lesion. Of course, she could possibly also have just a primary membranous, but having this lupus serologies there will obviously sway me more towards this being secondary, and PLA2R is negative. So I'm still thinking lupus as a systemic disease and membranous specifically as a renal lesion. She also had COVID recently, and nephrotic syndrome after COVID could also be seen. The lesion would be a collapsing FSGS. Again, the lupus serologies would not be usual in that case, but that should be on the differential. Could she have IgA nephropathy? She has hematuria. She has a lot of, she has proteinuria, and she's young. Is she Hispanic?
Yes.
Yes, she was.
Yeah.
Yes.
So that all also could fit. But again, the lupus serologies will make that on the list, but lower. Minimal change diseases. So all the nephrotic differential, which is membranous, FSGS, minimal change are possible. But I think 38-year-old Hispanic female that comes in with these serologies, I would assume this is lupus until proven otherwise. The SSA is interesting. You can see that it being positive in lupus. Could she have Sjogren's? I didn't hear anything systemically that would suggest that. Sjogren can be a cause of cryo as well. In fact, it's probably the most common autoimmune disease cause of cryo, but it would be a mixed cryo, and her rheumatoid factor at least is negative. So I would probably put that a little bit lower on my differential. So I'm going to say this patient has systemic lupus with a membranous lesion that's leading to a hypercoagulable state. I don't see any medications like a birth control pill to kind of blame the PE on. So I would think this is part of her lupus spectrum and the nephrotic syndrome spectrum disease.
So I'm going to get to some questions in the chat. Earlier it was said, somebody said, can we just assume that this is membranous? And I think that's probably based on the pulmonary emboli, which are presumably from renal vein disease, although we don't know that. I think we kind of already talked a little bit about that and the need for biopsy, whatever. So COVID has come up. Patient had COVID about a month ago. What about Covan?
Yeah, I did say that she could have a collapsing FSGS
Roger?
from her COVID, but then how do you explain all of a sudden that her anti-double stranded DNA, ANA are positive? So those two things kind of make me think that this is more like a lupus lesion as opposed to that. But that's possible. So we'll have to see on the biopsy if that's what she has.
I mean, what I was getting at
Roger?
actually was the association of APOL1 to collapsing FSGS, and I know it's very strong. I don't know. I mean, how often do we see Covan in Hispanic? Any thoughts, anybody?
Roger?
Yeah, Dick.
I'm very surprised, coming from Rush, that lupus podocytopathy is not in the differential diagnosis. Did you hear me?
We did. I'm going to let Casey comment on that.
It was a bit of an echo, but just to repeat, he was wondering about isolated lupus podocytopathy in the differential.
Absolutely. That should be on the differential. I missed that. So yes, I'm going to put that on. Thank you, Dr. Glassick. She could have that. Absolutely.
The reason I raise that is that I think in light of the bilateral life-threatening pulmonary emboli, the question might have been raised as to why not treat her with steroids and not do a biopsy. I'll just raise it because I think all of us would have been very nervous about doing a biopsy without any anticoagulants in a patient who had a recent life-threatening pulmonary embolus. I just want to know what the clinical reasoning was in this patient.
I completely agree. I think we thought about that. We thought about doing empiric treatment, but we also thought membranous was very high in the differential because of the PE and maybe even lupus membranous. And I usually don't go with empiric steroids alone, or I don't usually go with steroids alone for my treatment of membranous. So I thought it really was going to change our management here. I think someone in the chat said the differential was quite narrow, but I'm of the belief that the differential is quite wide. The podocytopathy and membranous are treated differently. It could be COVID associated, which is viral associated, which may or may not need any immunosuppression. She had obesity. She's got a family history of Alport syndrome, and she had some hematuria with that as well. There's so many things in this differential that I thought we really needed to pursue this biopsy.
Here's something to throw kind of a fly in the ointment as well. I'm trying to catch up with my reading, and just this week in the New England Journal of Medicine, the whole issue of anti-nephrin antibodies. They brought up the case of a membranous patients who had anti-nephrin antibodies and went back and brought the issue up of whether maybe two things were coexisting. PLA2R positive membranous plus the anti-nephrin antibodies. So I wonder, if patients now that we previously talked about having a lupus podocytopathy may actually have anti-nephrin antibodies associated with that as well, which would be something interesting to look into. When they looked at patients in that particular study with lupus in general, they didn't find any that had antibodies. But I think it is food for thought once that assay becomes available. Plus, there are obviously some histologic features that might be suggestive as well.
So someone mentioned in the chat, APOL1 is common in Hispanics. I don't know about common.
No, it's actually not common. It's about 10 to 15% of Hispanics may have APOL1, but that's when tested. Obviously, there are a lot that haven't been tested.
But I think that's an important point. It's not nothing,
Right.
but it's not common either. So I think that is a reasonable thing to put in the differential diagnosis. Because I tend to not think about that. So I'm glad that was brought up.
That actually sounds high to me. Is that really that high? Because I know in African Americans, it's around 15% or so, depending upon where sub-Saharan Africa would be a little higher. But in European whites, it's less than 1% generally.
Sorry, what I meant to say is that of all the APOL1 people that are positive, 10 to 15% are Hispanic and not Black.
Got it.
I don't want to make a big thing of this, Roger, but I've seen a lot of patients with lupus membranous, and I tell you, I cannot remember a patient who had the abrupt onset of nephrotic syndrome, who had lupus membranous. I put a lot of weight in the fact that this patient came in with a pretty severe nephrotic syndrome on serum albumin of 1.8, 2 weeks duration. That doesn't smell like membranous to me.
Yeah, I think that's a reasonable point. I would say that podocytopathy, though, causing this degree of pulmonary emboli, I would also find a little bit unusual. I just have such a strong association with membranous, but that's often idiopathic membranous, and it may not even apply to lupus membranous. So, I think it all gets back to this. A lot of people just buying the empiric treatment. I have to agree with Bill. It's a pretty complicated thing. And even if it's podocytopathy, do we really know how to treat podocytopathy? People have treated it like minimal change because it looked like minimal change. And for the longest time, it was thought to be people that had podocytopathy were thought to have lupus and minimal change, as opposed to the podocytopathy being a lupus related lesion. And maybe that should just be treated like lupus with perhaps MMF or something. So I'm not even sure we know how to treat a lot of these lesions, podocytopathy by itself or lupus membranous by itself or whatever it is by itself.
That gets back to the whole issue, anti-nephrin being an autoimmune disease. In lupus, they can make all kinds of, there are all kinds of immunologic expressions that they have. The patients that get subendothelial deposits have immune complexes that are very different than the ones that get membranous. And who's to say that these patients, that lupus patients might not also be making anti-nephrin antibodies? I think it's just an interesting concept that somebody, at some point needs to be looked into, and I'm sure it will be once it becomes a little more available as far as an assay goes. But they can have, I'm sure they can have more than one type of antibody being produced, and if it's against nephrin, then possibly they do have two things coexisting. It'll be interesting to see if there's, we'll say, background membranous, and then all of a sudden you've got this little speckling in the cytoplasm of the podocytes that make you think about anti-nephrin antibodies, which gets back to the whole issue again of two things going on, but it's in a lupus patient who's just making you know, antibodies to nephrin in this particular case. That whole area, which you guys have brought up numerous times, I think it's kind of opened up a whole new way of looking at, for sure, podocytopathy, because some patients with, you know, FSGS will have this as well. And as an aside, are we calling it idiopathic membranous again, or is that Roger?
Well, yeah, whatever. I'm gonna move. Dr. Reen, you wanted to say something?
Yeah, I'm just wondering, we are making the diagnosis of lupus only on the basis of serology. I don't remember if it was mentioned it had joint pains or skin rash or sun sensitivity. So
Clinically, she was clinically quiescent.
This could be like a latent lupus, if you will, presenting with membranous.
latent lupus, okay, if it exists. I think think more like a podocytopathy, and it would be nice. I think biopsy is indicated under the cover of heparin. I have done it safely in the DVT patients, and you stop it for 8 hours and restart after about 8 hours. I didn't have any issues with bleeding. So I think biopsy is indicated. It would have been nice if we have assay of anti-nephrin, which will eliminate your biopsy at that time. The picture looks like podocytopathy, whatever the cause is.
So anti-nephrin would be interesting, but you know, it's another autoantibody. Just that, you know, lupus has a lot of autoantibodies. So there's some people with lupus have PLA2 antibodies, and it's thought to be not so much two things, but that's another autoantibody. But to your point, it will be really good when we know more about anti-nephrin and be able to maybe perhaps measure it and follow it and see what's going on. Arun, and I'm not going to say your last name out of respect for not totally messing it up, but said, shouldn't a pure podocytopathy have deranged lipid profile? That kind of gets back to what I was saying, that kind of the assumption was that lupus podocytopathy is really minimal change. And, you know, it really isn't minimal change, but I don't know about the lipid abnormalities in lupus podocytopathy. As I remember, they're nowhere near as severe as they are in you know, idiopathic, or whatever we're going to call that, minimal change, and primary, whatever we're going to call that, focal sclerosis. So I don't know if that would apply either. I don't think it's quite the same. I don't look at lupus podocytopathy. They don't respond. They respond to steroids, but nothing like as well as, you know, on and off like minimal change. In my experience, they get better, but they don't always. It's not an all or nothing condition, which is really the case with minimal change, more so than focal sclerosis. Any other comments? I want to ask. I hope I don't blow this. Dr. Obadi, welcome from University of Chicago. Can you tell us what you think is going on?
Yeah, hi everyone. Nice to meet you all. Very interesting discussion. I think I'm along the same lines, you know, thinking this is more like a podocytopathy due to underlying lupus, although it could also be post-infectious GN in the setting of COVID. I do think a biopsy is necessary because, like you said, you wouldn't want to immunosuppress someone without really knowing the cause. I do recognize the risk of, you know, biopsy with anticoagulation in the recent PEs, but I do think we need some answers to kind of delineate what's going on.
I know that at U of C for a while there, your pathologist wasn't doing a PLA2R stain. Is that still true?
It's still a send out, I think. We're doing that more of a send out.
Okay. So it's not an automatic.
No.
Okay.
Yeah.
Well, I think it's time to take a look. And we'll see who the wheel. We'll see. That's still that picture, yeah. But the real wheel has everybody's name on it. So if you want to put the wheel up. Steve's at the airport. Dr. Height. Dr. Gashty.
second here, Casey. Spotlight.
We'll,
My day.
we'll see.
Should go buy a lottery ticket.
We'll see if you were right about yourself.
I know. I'm gonna make it right. I'm gonna miss the podocytopathy and see membranous.
All right, Casey, go ahead and click. Yep, you're controlling
Got
it.
it. Okay.
Yep.
All right. Okay, so here's a low power trichrome. I almost see no blue. This is like perfectly preserved, zero fibrosis, great core.
Yep. Yeah, I agree with you, Casey.
All right, I'm just gonna move on to the higher power. So here's a glomerulus on H&E, lower power, kind of hanging off the edge, but I do see open capillary loops. I don't see any, well, I can't say I can't see any crescents because half of the capsule is missing, but it looks, at least the tuft itself, there is mesangial hypercellularity, but there is no, let me see, I'm trying to look and make sure there's no capillary hypercellularity, which there isn't. I think this is mesangial expansion, some hypercellularity. These capillary walls don't completely look normal, but I always kind of try to reserve judgment for another higher maybe power. There is a little bit of maybe like a double contour right here at 4 o'clock. I'll wait on that.
That might just be a little on FOSS.
On FOSS, okay.
But I do agree they are mildly thick, and like look up at 12 o'clock. They're also, yeah, and to the left of that one a little.
Oh, here.
Right there, yeah.
Yeah, I see.
A little
Yeah,
more
and
refractile.
yeah, a
and
little
thicker.
granular too. Okay. All right. Tubules. This is a proximal tubule. Here at least there's a little bit of a loss of brush border, but I'll just look at the bigger picture here. Here's another glomerulus. Again, there's mesangial hypercellularity. Again, you can kind of see here at like about 8 to 9 o'clock, there's thickening of the capillary walls here as well. There's a slight, like a bluish tint to it that I usually don't see. So that's why I kind of thought there was something there. But mesangial hypercellularity, at times you can kind of see maybe up to 5 to 6 nuclei per high power field. Mesangial expansion here. I don't see any necrosis and I don't see any crescents.
Right. Tubules, interstitium, all look fine.
Yeah, here's PAS stain. Now you can really see the brush border in the tubules. They look intact. This glomerulus looks very nice. You know, the capillary loops are open. Sometimes we kind of pay attention to how open they are, and sort of they're too proud or too stiff. That could be a hint that maybe there is a membranous component to it. And since that's where I put my nickel, that's what I'm going to go with. But I wait for the Jones stain and then obviously for the fluorescent and EM. But here, this glomerulus looks pretty good. There is really very little mesangial expansion, although mesangial expansion increases with age, right? So this, you know, is this degree of mesangial expansion abnormal in a 38-year-old, David, or is this pretty, I mean, this looks pretty normal, right?
Yeah. It looks pretty normal.
Okay. Yeah. Oh, wow. So we're jumping to the fluorescent. IgG is positive in the capillary wall as well as the mesangial space. There is some very thick deposits here in this loop and this loop. So this is sort of a, trying to think if this is just a really bad membranous or if do we have.
Yeah, I didn't see any wire loops.
Wire loops.
Yeah,
you don't think this is wire loop?
No.
Okay.
No, we would have seen them on H.
On H. Okay.
Yeah.
All right. So we have sub-epithelial IgG and mesangial IgG so far.
And that's granular, right? Granular staining?
Yes. Well, most of it was granular. And then here, this area that I thought maybe there's a suggestion of wire loop because it's a continuous. And also here.
Sometimes it's just a little thick in these areas and the deposits become confluent. So
Okay.
we really need to see them on H&E to call them wire loops.
Okay. Which we did not see.
Yeah.
This is a Jones stain. And let me find, oh, here, maybe at 11 o'clock, I can see spikes around the glomerular basement membrane. I'm looking at, there's some spikes here at 12 o'clock. Here at 3 o'clock. I
Quite a
don't
bit
see
of
any
holes there
holes.
also.
Yeah.
Yeah.
Where do you see holes?
Oh, where you just were.
Down here?
Yeah. Right, because that's kind of a non-phos section there.
Okay. Yeah, I see areas where there is less gray and there's, darker gray. But usually when I think of holes, I see kind of like there's one here. I see kind of those widespread. But if you say these are holes, these are holes. You're the pathologist.
Yeah, I mean, this is really moth-eaten. I mean,
Yeah.
if it was normal, it would just be a nice kind of ribbon-like
Yeah,
black.
it would be like thin and delicate like this here. Yeah. Yeah. I mean, there is definitely suggestion of immune complexes here. Exostocin is negative with a positive control. Nice.
Yeah, and we did not get a sample for EM.
Hey, David, what about the rest of the IF?
It was full house, IgG, IgM, IgA, C3, and C1q.
And PLA2R was negative also.
Yeah.
Well, the fact that there is a membranous, that essentially from a nomenclature standpoint won't be a podocytopathy, right? So does the EM matter that much here?
Oh, I don't think so.
It's a tough question because, podocytopathy, we sort of believe, at least at Rush, that any foot process effacement in lupus should be considered a concomitant podocytopathy. When we talk about podocytopathy in lupus, we really are referring to, if it's just that alone, we would call it isolated podocytopathy, similar to we would say isolated membranous. However, we don't know if that changes any treatment. We do know that the nephrotic membranous patients more often have diffuse foot process effacement than the non-nephrotic. So we do think there's some significance clinically there, but we don't know anything about treatment. And again, maybe Nephrin will help us sort that out in the future too.
So if let's say this lady if we had EM, so she has membranous, and if she had more than 80% foot process effacement, would you call this class 5 plus podocytopathy, or would you call it class 5 only?
That's exactly what I think that it should be called, is class 5 plus podocytopathy. And that can exist, Casey, even in a DPGN. If there's diffuse foot process there and nephrotic syndrome in the setting of a DPGN, it should be the DPG, or it should be the, class 4 plus podocytopathy. That is not widely recognized, and I'm not going on record saying that the people that are doing the classifications are listening to me, but that's definitely in my editorials and so on about podocytopathy.
Casey, are you comfortable that there's enough here to say this is lupus pathophysiology?
Okay, so we don't have an EM. So one of the things, so first of all, there's mesangial deposit. So that helps me move more towards a secondary type of membranous. And with the patient's, sex, age, positive ANA and double-stranded DNA, and presence of membranous and deposits in the mesangium, those things make me feel more comfortable calling this a secondary membranous and due to lupus. If I saw TRIs on an EM, that would help me even more. We don't have that, so it is what it is. But I feel comfortable calling this secondary membranous due to lupus.
The other thing that would have been helpful too with the EMs is because Ron Falk and Charlie Jeanette looked at this years ago and talked about finding mesangial hypercellularity, TRIs, and then subendothelial deposits. You don't have to have wire loops, but if there were subendothelial deposits on the EM, that'd be yet another factor that would be helpful in kind of suggesting that this is a membranous associated lesion with lupus.
Yeah, I agree, Casey. I think there's enough there. I want to get back to something Dr. Corbett said. He used the term latent lupus, and Dr. Reen kind of scoffed at that, said, well, if that exists, just having fun. But, well, I think just to say what he's referring to is a lot of these patients will present without systemic symptoms and later get some systemic symptoms and you go back and you look and you say there's probably lupus all along. I would take it a step further. A lot of these patients never get systemic symptoms. They have isolated, GN, and that would be why I kind of don't even like the term latent, because I just think it's lupus membranous. And sometimes, as it was pointed out in the chat, the serologies, the complements are often normal. The serologies are often not that impressive. And you're kind of left in a little bit of a gray zone. And what's certainly helpful is what, Casey brought up, mesangial deposits, et cetera, some low-grade serology. I have no problem putting it in that category, because it kind of does matter how you think you're going to treat this patient, I suppose. And I think Dr. Whittier is going to talk about that. Exostocin was negative, Dr. Reen. We need some time for Bill to talk. I know he's got some slides. Casey, well, actually, let's do the poll first. Yeah, I'm sorry. Let's do this poll first. How would you treat this patient? Number one, a Rituxan-based protocol. Number two, MMF and prednisone. Number three, a Ponticelli-based protocol, which means cyclophosphamide. Or number four, CNI-based protocol.
I think I remember a patient that I presented to the group about a year ago. The guy with anticardiolipin antibody, renal vein thrombosis, and membranous type of picture. And we had a lot of discussion around treatment. I remember Dr. Glasik suggested me MMF and prednisone. Unfortunately, he developed severe systemic symptoms with the MMF, and we discussed a little bit of that also. We ended up treating with Rituxan, and actually his protein is totally normal. I should mention that he was exotin 1-2 positive, which had a better diagnosis, and his lupus serology was totally negative. So from that experience, I would say I like rituximab protocol in this man.
All right, let's show the results. A third of the people agree. We've got 33% is Rituxan. About half wants to use standard Alms protocol, MMF and prednisone. 10% want to go with cyclophosphamide, and a couple of people are still sold on a CNI-based protocol. Casey, what would you do?
Well, I think this PE is bothering me a little bit, so I kind of want to make sure her proteinuria kind of goes away a little faster. So for that, I think I would like to maybe do a combination of CNI and then Rituxan, so that we can kind of acute, sort of like a short-term versus long-term proteinuria reduction, because that's really what we're talking about here is complications from what's happening with her nephrotic syndrome, and the quickest way of lowering proteinuria of the four would be CNI.
Would you be concerned that if we use Prograf, which has prothrombotic property in itself, so we have to monitor INR really closely?
I mean, she's on anticoagulation, and yeah, I don't know. I don't have enough experience with the thrombotic complications of CNIs to answer your question. But if she's on anticoagulation, I would assume that would be okay, but I don't know.
Anybody feel strongly about any of those options?
Well, in terms of evidence, the MMF and prednisone is probably the best choice, because we don't have any clear studies indicating that rituximab is efficacious in this situation. But I understand the anecdotes that Dr. Breen has presented, and I suppose if you want to use experience as your guide, then you might use rituximab. But if you're using evidence, I think MMF would be my choice.
So So that is MMF is that's your final answer, Dick?
Yep.
Okay. Well, Bill, why don't you walk us through your thoughts about this and what you decided? For those of you that don't really know, his nickname is Rituxabil. So we'll see if he's going to waver from his nickname.
Yeah, we'll see, huh? Yeah, I think it's nice to go over this evidence and just as a reminder, exostosin is not the only antigen associated with lupus membranous. It's the one that's the most talked about, and certainly is the only one that I know of that's sustainable commercially, and that's why we checked for it. And it was negative in our case, just like PLA2R was. But there's a couple others out there, such as transforming growth factor beta and also this NCAM1 that are associated with lupus too. So, hopefully in the future we can have a panel that kind of just gives us the idea of all these different things, and we could avoid a biopsy, especially in a patient like this. But obviously, when you're in this autoimmune history, or you've got your full house standing and mesangial deposits, you're sort of really looking about your membranous, especially if it's already PLA2R negative, just like our case was. You're going to be thinking it's one of these. This contactin is really more of the autoimmune neuropathy, not necessarily lupus description, but these kind of three are the ones that are associated more with lupus membranous. And so that's kind of what we're thinking that she might have, although we don't really know that. So what about treatment? That's kind of the big, the gorilla or the elephant in the room here. And here's from KDIGO, pure class 5 lupus nephritis is what we're talking about. So we're not talking about proliferative or, diffuse proliferative or segmental necrotizing lupus. It's really just pure class membranous. And KDIGO is fortunately relatively vague and gives us a lot of choices. We can use MMF, cyclophosphamide, a CNI, rituximab, or azathioprine. And it says there's insufficient evidence for glucocorticoid alone, which is part of the reason that I thought it was so important to biopsy her. But I'm going to kind of talk about rituximab since I'm Rituxabil. Thank you for pointing that out earlier and showing my bias. But first, I just wanted to talk briefly about the treatment of membranous in the literature. And I wanted to go straight to the ALM study, which I can't believe this was back in 2009 already, such a landmark study. And it looked, of course, at MMF versus cyclophosphamide for induction in lupus nephritis. And most of the patients, I just want to point out here, were either a 3 with 5 or a 3 and 4 with 5 or a 3 and 4 alone. Very few patients in the study were membranous, isolated membranous, what we're talking about. But there were some here. And these patients actually aren't that common in terms of all patients with lupus that are biopsied. They had about, I guess, about 15% had isolated membranous only. And they were also randomized to receive either CellCept or IV Cytoxan. And their response rate was about 50%. So it was about 48% in the Cytoxan arm, and in the MMF arm, it was 55%, and that wasn't statistically significant. And it's sort of mirrored here with their remission rates were for the responders in class 3 or 4. And just to point out that 50% is not very successful as far as treatment of glomerulonephritis. And it's kind of where the standard has been in lupus for a while. But if we think about our treatment of, encapsulitis, we're closer to 80%, and a lot of our other ones are much more successful. So I'm just so happy that a lot of these studies are still ongoing and providing new therapies for us that might get this up way past 50%. So let's go back to, instead of looking at all comers with the ALMs, let's look at just the pure treatment of, membranous lupus nephritis. And this was not a randomized controlled trial, and it went back to the Ponticelli regimen, which was one of the first ones that I found in 1998, showing that he gave them the Ponticelli regimen like he would for primary membranous, as it was called then, where he gave methylprednisolone and chlorambucil versus steroids alone. And I would argue that even though this did not achieve statistical significance, that these have a pretty big separation. The p-value is 0.14, and it's retrospective. I'm not saying that it means we need to be treating with Ponticelli regimen for lupus membranous, but it sort of does look like something more may be needed, and that possibly steroids alone are not going to be that effective. This was sort of, again, how it was in 1998. And I mislabeled this as overall survival when it was talking about the renal survival to progression to CKD. So that's a typo there, sorry. So how about 1 month before the ALMS trial came out? This came out in JASON, which is a randomized, the only RCT that I know of to date in pure lupus membranous nephropathy. It was by the Austin group and the NIH, and they randomized patients to one of 3 different arms to either get cyclosporin, which was kind of the prevalent thought of how you treat membranous at the time. I'm talking about primary membranous in 2009, versus IV cyclophosphamide versus prednisone alone. So those were the 3 arms. And what the Austin group found was that cyclosporin and Cytoxan were superior to prednisone alone. So that we didn't know which one of these was better, although this looks like there's separation here. Statistically, it wasn't. But the point was that prednisone alone is not very successful at inducing a remission in membranous nephritis. And of course, as we know with almost every cyclosporin or CNI-based regimen, at least with Prograf and cyclosporin, when you stop the cyclosporin, you're going to have a higher rate of relapse versus the IV cyclophosphamide, which maintained the relapse-free survival for much, much longer. And we would see this same sort of thing with Rituxan versus cyclosporin in primary membranous in the Mentor trial. But again, we're trying to keep it focused on pure membranous lupus. So what about the LUNAR trial if we're talking about rituximab? The LUNAR trial was considered to be a failed trial, and what they did was they randomized patients with lupus nephritis, active only. They did not have pure membranous in this trial. And what they did is they had their standard steroids plus MMF versus steroids plus MMF plus rituximab. And there ended up being no difference in safety or efficacy in the active treatment arm with rituximab. And this was like a dagger in my heart because I'm Rituxabil, but we've got to follow the data. So if it doesn't work, it doesn't work. Oh, I had another slide in here. Sorry. I had another slide which had, so I must have sent you an older copy, Pravir. But what I did want to point out, and what that slide said, was that they actually looked at follow-up patients who who achieved B-cell depletion in the LUNAR trial. And what they found in those that achieved B-cell depletion, there was a higher rate of remission in patients with active lupus. And so I don't think the Rituxan should be dead for lupus. I don't think it should be dead for active lupus. I think that we need to focus on achieving B-cell depletion if we're going to choose to do that. And so for really,
Bill,
yes.
do you remember the dose that they used back then? Were they doing the standard 2-gram type of dose, or?
That's a good question. I don't know that. I could look that up and get that for you, though.
In LUNAR, it was the 375 times 4.
Times 4, okay.
And they did look at, but even that achieved B-cell depletion in a certain subset. And so those that achieved it actually had a much better remission.
Didn't they also get cyclophosphamide?
In LUNAR, it was, well, maybe there was a subset there for induction, but I know that I thought their standard was CellCept for induction.
Okay, MMF, fair enough.
And Pravir, I don't know what happened to my slides. Do you know? Can I get them back up?
That's me. Give me 1 second here.
The problem I always had with LUNAR is they added rituximab to MMF and looking for an effect. And MMF, as we know, is a pretty good treatment. So maybe it didn't help to add it, but it doesn't mean that that you throw the baby out with the bathwater. In other words, that it's not a useful induction therapy. It may not be an additive therapy. It really didn't ask the question that I thought should have been asked.
Well, it's hard because you have to do standard of care, and then in the studies now too are adding on as induction therapy for voclosporin or for the Benlysta and things like that. And so, and remember in lupus the complete remission rate was really dismal. 50% is not that great. But look at this. This was the study I was talking about where they achieved B-cell depletion, and then they just received a much higher complete remission rate versus those that didn't had only a 13%. So I think this really gives a lot of ammunition for if you're going to use it, and I'm not saying that it's really part of our armamentarium for active lupus, but in here, if you're going to use it, want to make sure that you definitely get B-cell depletion. And so speaking of B-cell depletion, we go to the next one. That has to bring up the drugs that deplete B cells more so than Rituxan or to a greater degree than Rituxan. And we talk about OB with this. And this was the Nobility study, which randomized patients just like the LUNAR trial. It was add-on therapy of OB compared to CellCept and prednisone for active lupus nephritis. And they achieved, with the add-on therapy of OB to MMF, they achieved a greater complete response rate and overall response rate in the group that got OB. And so I don't think that we should be throwing out rituximab, but again, not pure membranous in all these patients, and that's kind of what we're getting at, right? And so that's where we are. And so what about the other study that's looked at besides the LUNAR trial that looked at Rituxan is the Rituxaloop study, not a randomized controlled trial. It's a cohort series, Liz Lightstone, 50 consecutive patients. And what she did was she gave them MMF and some IV Solumedrol and then Rituxan, and all 50 patients got it. What was interesting though is that about 40% of her patients had pure lupus membranous, which was higher than other studies have reported the amount of membranous lupus, but that means that this cohort arguably had quite a bit of, pure membranous lupus. It did. And they had a pretty successful 90% CR or PR over 37 weeks with no oral steroids, the one-time IV Solumedrol, CellCept, and Rituxan. Okay, and this was in patients with lupus, and a lot of them had pure membranous. Now, when we're looking at, so that was Rituxan with CellCept. When it comes to Rituxan alone for pure membranous lupus, the data is scarce. Okay, this is about all I could find, except for a couple single case reports here and there. 15 patients, pure membranous lupus, Rituxan alone, no CellCept, no steroids, and they achieved actually quite a bit of remission. They had an 80% total remission, 80% complete and partial together, very few rituximab failures. Look at the proteinuria at baseline, 4.9 grams, achieved, let's see, the serum albumin went up, the proteinuria went down, the creatinine stayed the same, serologically they got better. So I'm not saying this is the holy grail, it's 15 consecutive patients and there's no control arm, but it's a nice way to look at if you want to avoid steroids and avoid CellCept, that at least this has been reported. So should we really, what I'm getting at is, should we be treating our pure membranous lupus similar to we treat our PLA2R positive membranous? And I don't know. I don't think we have data to support that answer. But what I chose in this patient, given the fact that she was obese and still had some positive serology, that even though that one sub-study showed that it did improve the serology too, I chose to treat her more like the Rituxaloop study, Liz Lightstone study. So I decided to treat her with CellCept and Rituxan, very similar to what Liz Lightstone's protocol is.
Do we know, do we have any follow-up?
No follow-up yet.
So
we also got antiphospholipid antibodies real quick. Sorry, just because she obviously had the PE, and I know that Dr. Reen had brought that up as well, and hers were negative.
Yeah, I think that's important. I did a quick Google search about pulmonary embolus and renal vein thrombosis with lupus membranous, and very little came up. But what did show up is often if they do have that, they've got antiphospholipid antibodies. So it's interesting. I think this is a little bit unusual that she, basically presented with pulmonary embolus, and I think that's kind of like interesting in lupus nephritis, or at least lupus membranous. So, Bill, is she bought anticoagulation for life, or what? Or do you think she'd get in remission, or what?
No, we actually had her see heme, and they said that she's going to need it as long as she remains nephrotic and has a low albumin, and she's going to need it no matter what for at least 3 months, is all they said. But if her nephrotic syndrome was gone at 3 months, from the pure PE standpoint, they were going to stop anticoagulation at 3 months.
And that's actually really important that you now know that the phospholipid antibody is negative, because if it were positive, you really wouldn't know how much the thrombosis was from nephrotic syndrome or that.
Right.
Dr. Rubin, you have a comment?
Actually, I have more than a comment. I mean, number one, I think that I hope that today's case is yet another example for the non-believers in the audience that shy away from a diagnostic, therapeutic, and prognostic kidney biopsy. Number two is that we no longer live in the Bill Silverman days where a kidney biopsy was potentially a disaster. We have better needles, better technique, and we have experienced people such as Bill that know what to do. So if you are afraid of doing a kidney biopsy in a given patient, send that patient to a referral center. And the next question I have is for Bill, is the exostosing was negative in this patient. We do know from the data from the Mayo, from Dr. Setti, that the presence of exostosing portends a better prognosis. Does the absence of exostosing portends a bad prognosis for membranous lupus?
That's an excellent question. I don't know the answer. I can look through and set these papers and see if that data exists, which it should.
Okay, and my last comment is that after your outstanding review of the treatment of membranous lupus, we are in the same place we were many decades ago. We have no idea how to treat membranous lupus. Thank you.
I couldn't agree
I think
more.
we also know that prednisone alone doesn't work. That was very helpful in 2009, the randomized control trial, right?
Right.
And I think that's important because prednisone doesn't work for PLA2R. I mean, we used to call idiopathic membranous. So I think that is really important. But I think Mario's spot on. We're kind of close to, when you look at all the studies out there, where it was a collaborative study group and ALMS, et cetera, they all have a spattering of class 5, and a lot of them have a mixture of class 5, but a lot of them have 20, 30% of just class 5, which I've never really liked the fact that those were included in there, because I've always thought these studies would be about induction for proliferative lupus, but they're there, but they're not powered to tell us anything. So you're kind of stuck. I mean, you've got some information there from in Dr. Lightstone's and the like, but it's really a problem, and I don't know that this will ever be done, because to power a study on lupus membranous alone is probably not going to happen. So we're kind of left with anecdotes and philosophies and nicknames like Rituximab and et cetera. But and Dr. Glassick, I mean, he's a purist. He says the literature is to use MMF, and you can't argue with any of this. I think that CNIs are kind of falling out. People talked about voclosporin in the chat. I'm not a big fan of that approach. I think that I would want to attack this immunologically and not just with voclosporin, but that's always a possibility. I think there's not much evidence of, that's really been tested as an add-on agent anyway. Mario, I have one question for you. Do you know what eponemic and transmogrified mean?
No idea. I just learned them today.
That's why we love you and your honesty.
Dr. Glasser keep us on our tippy toes. Never.
Well, any other comments, anybody?
We have to end on that. We began on it. We must end on it.
All right. Thanks, everybody. Next week, Dr. Whittier, Dr. Rodby, and Dr. Glassick will be in Maui at the GlomCon conference. I hope some other people here will be there. So we'll be off that week. We'll be back in 2 weeks. In the meantime, enjoy the Olympics and root for your country. Thanks, everybody.
Thanks very much, Roger.